Hi, everyone. Dr. Hess here for Chapter 3. Chapter 3 is all about assessment and diagnosis. We're going to go through it really rapidly. I'm really trying to keep these videos short. The last one was a little bit long. We had a lot of material. So let me bring up our PowerPoint here. And we'll start our slideshow. There we go. So assessment and diagnosis, probably one of the most important practices that clinicians, doctors, psychologists, counselors, therapists um, uh, do. And this is assessment as far as what kind of mental disorder is being presented to us in our patient or client. As you can probably tell, it's very important that we are as accurate as possible. So we'll go through some of the tools that counselors have to make an assessment and then make that diagnosis. So let's take a look here at what we have. So the first thing we want to look at in our assessments is kind of the gathering enough information from the person or from observing the person so that we can start zeroing in on what is the problem. So then we can make a treatment plan to help them alleviate their symptoms. Validity is the important thing. Validity is the word that we use to show the accuracy of any kind of test or method we have for assessing what we're supposed to be measuring. So is the tool we're using actually measuring depression or actually measuring anxiety? If it is, then it has some validity. The diagnosis is the label, and a label is a kind of a powerful word, but it is the label or the identity of whatever syndrome or symptom set of symptoms we have, we see in the patient that we need to address. Let's keep going on. Reliability. And this is for the tools that kind of maybe a psychological test or inventory. How reliable is it? How consistent is it? So if we give the test over and over again, does it actually measure what we want it to measure with the same consistency? That's kind of the important thing. It's the standardization across these different things. So how do we do this? Probably the most common is the clinical interview, and that is where you sit down with a therapist or your doctor and they ask you some questions and you try to answer and they look for some clarification to your answers. And they're looking at it. Sometimes it's a structured interview where they're going down a list of questions. I think we see this more and more now that doctors and psychologists and psychiatrists are using, laptops in their offices. They're going down and checklist so that they can make sure that they ask all of the right questions. Here's a little sample of some of the structured interview questions. Again, I'll ask you to come back to that if you want to. Aaron Beck was one of the original fathers of a lot of these inventories. He has the Beck inventory for anxiety, Beck inventory for depression, Beck inventory for you name it. You can Google it. Most of them are online so that you can actually take them, and some of them are self-scored. They're pretty easy, very few questions, but they're pretty accurate, have reliability and validity to them. The MMPI, the Minnesota Multiphasic Personality Inventory, is probably one of the most used inventories. Has a lot of questions, over 500 questions, true false questions, and can really give some accurate assessment to the person's personality and what might be going on with them. These are the scales of the MMPI, and you can see that of all of the scales, there's a lot that they are looking for, such as depression, hypochondriasis, hysteria, paranoia, schizophrenia, just to name a few. Let's see. Another way that clinicians can start making an assessment is basically watching them, watching the person, how they act in the office, or sometimes we can, in hospital, we can watch them, how are they acting in group, or how are they acting when they think no one's looking, and putting together some behavioral aspects to the person. A lot of time nowadays, we have self-monitoring. This is where and this is because we have smartphones and everybody's carrying around little mini computers with them, that you can actually check in with an app on how you're doing, and you're self-monitoring your symptoms. How anxious am I right now? What's happening? Making a note in the app, or taking a little questionnaire in the app, and then your doctor will be able to look at it. Another way we can look at assessing someone is through intelligence tests. They're not used much anymore, but as far as trying to get some psychologists still use these, is to kind of get a kind of a baseline for how they're functioning in the world. There is a lot of controversy around intelligence tests because of the cultural problems that we have with the questions. There's neurophysiological tests. These are ones that are looking for do we have a brain dysfunction that is causing the person to have neural problems. And the Bender Gestalt is one of them. This is a picture of that, where they are given figures to draw, and then they try to draw them on the other side, and you can see how accurate they are at copying these figures. Nowadays, we have a lot of brain imaging techniques, large, gigantic scanning equipment, CT, PET scans, and MRIs are looking into the brain, seeing the different, looking for different structural or functional problems in the brain. Electroencephalograms are looking for any kind of electrical problems that might be happening in our brain, and can measure a lot of different other things, such as heart rate and respiration rate, things that kind of look like lie detector tests. Hooked up to that, you can look at a lot of the physiological aspects of people while they're being interviewed, or maybe even looking at pictures on a screen of a computer. Projective tests are used a lot with people who are having trouble being verbal with their problems, oftentimes used with children who might not be able to identify their feelings. We can use projective tests. They are such tests as house, tree, person, where you ask the person to draw a house, a tree, and a person. A Rorschach is probably the most famous of these, where you look at ink blots and you tell your doctor what you see in there. There's a lot of these tests are kind of fun to take if you're interested in them. There's a bunch of them online that you can play around with if you wish. Let's keep going. So to get a diagnosis, and we talked before that all clinicians, doctors, counselors, will need to have a diagnosis before they start treatment. So we don't want to start treating something until we know what it is. And the insurance companies will require a diagnosis out of the DSM. We'll be seeing those in a slide coming up. That's the big Bible of diagnosing for psychological. But a diagnosis is basically a bunch of symptoms put together in a cluster that we see together, and then the people that came before us, the giants in the world of psychology, have given them different names, so that we'll see that that's happening. So, and you'll see that some symptoms, such as anxiety and depression, overlap, and so it can be a bit troublesome sometimes to make an accurate diagnosis as quickly as we need to in the office. There's the classification, and here's this DSM. We're at DSM-5 right now, and we have a lot of the mental disorders are categorized, put with numbers, with all the different symptoms in lists for us to do. And a lot of times they'll say, of this list of 10 things, the patient or client needs to have at least 6 in order to have clinical depression or generalized anxiety disorder. The DSM-5 has been out for a while, and we don't know when the DSM, 6 will come out, or DSM-5 Part 2, but we'll see. We've left the axial approach. In the DSM-4, we had all of these axes. That was the way we would delineate the diagnosis for our patients. But we've moved away from that now, and we're more on a continuum, or a structure of from like a lot to very little continuum on most of our things. We see that, say, in autism. We use the word autism spectrum. As we're on a spectrum of all of these different things. There's a bunch of culture-bound syndromes, and they're very interesting that different cultures have specific syndromes that they notice in their population. There's quite a few of them here, like ghost sickness and amok, are interesting if you're interested in culture-bound syndromes. There is some dangers in diagnosing and some pluses. So some pluses and minuses, obviously. As I pointed out before, we need to have the diagnosis, but it also labels the person and can cause a person distress. It can also, on the flip side of that, the pro of diagnosis is that it oftentimes will help the person realize, well, I'm not the only person that has this. That gives me some relief to know that it's not just me, that what I have is a mental disorder that a lot of people have, and that a lot of people are suffering from it. And so it has pros and cons. Well, we talked about that. So we are at the end of our slide here. Back to, here we are at the end of chapter 3. Please skim the chapter, take a look at it for us. Keep working on your discussion boards, and I will see you in chapter 4. Bye for now.